Thank you, Andy and Leslie and Kopik for inviting me. This is an important topic. Hopefully you all find it relevant. Um, uh, no disclosures. So as opposed to last time when we tried to focus on just more general learning objectives related to colorectal cancer and screening, so mostly focusing on the average risk or general population. Tonight, I'm going to delve down a little bit more into how we would manage patients who are at increased risk for one reason or another. Part of that's going to be learning what risk factors are, then approaching patients who have symptoms. Often, technically patients who are screened with non-invasive testing and have positive test results are no longer average risk, obviously, and what should we know about follow-up for those? And then we'll end talking about family history and then some specific genetic syndromes. And I do have two brief cases to close out tonight. All right, so just to set the table again, this is data I presented last time, but as we all probably know, colorectal cancer, third most common cancer, second leading cause of cancer death in the United States, but also the world. Right now is the leading cause of cancer-related death in men under 50. And the average risk population, there's about a 4% lifetime risk. The good news, depending on how you look at it, is that over 50% of colorectal cancers can be linked to some modifiable risk factors. So those are tobacco use, alcohol use, diets high in red meat and low in fiber, sedentary lifestyle, and obesity. So those are the things that your patients can control, right? But tonight we're going to talk more about the non-modifiable risk factors and how we can help reduce those risks, at least through appropriate use of screening tools. So obviously age is one of them. The incidence of colorectal cancer increases dramatically as patients age. That's not going to be a surprise to anyone. Additional non-modifiable risk factors, so Black patients and American Indian and Alaskan Native patients have the highest risk relative to the general population, both in incidence and mortality. And then men are at higher risk than women in terms of both incidence and mortality in colorectal cancer. And then there's this other thing that I presented last time as well, but I'll touch on again tonight, is that there's the birth cohort effect, which has been identified since around mid of the last century. So starting in 1960, the risk of colorectal cancer has increased significantly with each successive generation. And that's despite reductions in incidence among older patients because of improved screening and things like that. So what does that mean? It means that adults born in 1990 have a two-fold increased risk of colon and a four-fold increased risk of rectal cancer compared to those born in 1950. So I was born in 1987. I have a significantly higher risk of colorectal cancer than my parents, just by the nature of my birth cohort. We don't know what's caused this, but it's likely that we will see this trend continue. And this is at least part of why we are seeing a rise in incidence among younger patients in incidence of colorectal cancer. So that obviously doesn't address the genetic risk factors like family history and genetics, which I'm going to spend a whole portion of the talk talking about later. So first part I wanted to address today was talking about patients with symptoms. So when we're thinking about average risk patients, technically those are patients who don't have any symptoms. They're not being referred for a diagnostic colonoscopy or other diagnostic testing. They're just being referred because they need screening. So what are the symptoms we should be concerned about? Well, first off, those patients who are enrolled in screening programs, most patients diagnosed with colorectal cancer do not have any symptoms. That's within a screening program, obviously. So the symptoms that we should be concerned about: rectal bleeding and iron deficiency anemia are probably the two strongest that correlate with an increased risk of colon cancer. Weight loss and change in bowel habits, there's an increased risk, but the connection isn't that strong. And then there's not a lot of evidence to support an increased link between abdominal pain or bloating or other kind of non-specific GI symptoms. Now, obviously, if your patient has a bowel obstruction related to their colon cancer, they're going to have pain. But in terms of kind of chronic symptoms that are linked to an increased risk and should prompt us to think about colon cancer. This is how we should think about it. And change in bowel habits really isn't like, your patient with 3 years of diarrhea. It's, do they have a relatively rapid change in the caliber of their stool? And more often it's constipation and things like that. And that's generally a sign of rectal or rarely distant cancers that would be causing a change in bowel habits. And then if you have 2 or more of these symptoms, that would increase your risk even further. So yes, to bring home the point, patients with symptoms should not really be considered average risk. Depending on the guideline you look at, different people recommend different approaches to these patients, but in general, you probably would not want to enroll them in an average risk screening strategy. What should you do? Well, if their age is over 40, then it probably makes the most sense, if you have access to it, to refer them for a colonoscopy, because they're approaching the age where the risk starts to increase for colon cancer, especially in younger generations. And in 5 years anyways, they'd be due. If their age is less than 40 and they don't really have any other risk factors like a family history, or they don't have kind of multiple symptoms, then a sigmoidoscopy is probably okay. There's actually newer data, which is, I think, relevant for those of us who don't have access to all the invasive testing we would like, that you can use non-invasive testing even in these patients to risk stratify. So there's a UK study that I believe was published in 2021, included over 3,000 patients with rectal bleeding. So that's just one of these symptoms, but probably the one we worry about the most. And they showed that in patients who had a positive FIT, the risk of colorectal cancer was 10%. And in patients with a negative FIT, that risk was all the way down to 0.1%. So it's a 100-fold decrease in your risk based on your FIT status. And then among those patients who had FIT negative and a normal sigmoidoscopy, their risk of colorectal cancer was almost 0. So that just gives you a little additional thing in your kind of toolbox in case you don't have access to endoscopy, colonoscopy specifically, for all patients. So what about an early onset colorectal cancer? So those patients are more likely to experience symptoms, which makes sense, right? Because they're not going to be in a screening program. If they're younger than 45, and therefore generally by the time they get to know about their cancer, it's because they're having symptoms. So greater than 50%. This is a study that looked at only 200 patients with colorectal cancer diagnosed before age 50, and in this patient population, way more than 50% had rectal bleeding by the time they were diagnosed. But the important thing to know here is that the stage of diagnosis strongly correlates with the duration of symptoms. So if you sit on your patient with rectal bleeding for a long time, by the time they eventually get the colonoscopy or sigmoidoscopy and the diagnosis, it may be too late. In this study that I mentioned, that with the 200 patients, in patients who are diagnosed with stage 1 disease, their median duration of symptoms was 30 days, whereas those diagnosed with metastatic or stage 4 disease, their median duration of symptoms was 330 days, or almost a year. So it's important to recognize those symptoms and get those patients in for whatever diagnostic testing you can, just because it does affect their ultimate outcomes. All right, moving on. Next, we'll talk about the follow-up after non-invasive diagnostic testing. So just to review, what are the most commonly used non-invasive tests in this country? So I'm pretty much just focusing on stool tests here. Years ago, FOBT was it. So that's just a guaiac screen for the presence of heme in stool. Doesn't look for heme. It's not human specific. So if you eat certain red meat or certain plants, if you eat a lot of red meat or certain plants, or vitamin C supplements actually will all cause false positives. And also that's a very high false negative rate. So really no one recommends using FOBT anymore for screening. Let's replace that as FIT. And FIT is different, that it's an antibody that detects human globin in the stool, so there's no dietary restrictions. It is also more specific. There's about a 5% false positive rate. This all varies depending on the study, but about 5% and a 10% false negative rate. And this is for any finding, not just for cancer. And then there's the multi-target stool DNA, which we all refer to as Cologuard. So this is FIT, but a screen looks for abnormal DNA markers in the stool. Again, no dietary restrictions. It's more sensitive than FIT for advanced neoplasia, like big precancerous polyps. It has a higher false positive rate, so 10 to 15% false positive rate, lower false negative rate, as you'd expect. I'll mention they're actually Exact Sciences, who makes Cologuard, is just applied or is about to apply for FDA approval for their second generation test, which is more sensitive and specific. And I think it brings, at least in the study that they're probably going to submit to the FDA, it brings their false positive rate down below 10%, closer to 5 to 7. So that's something that may be available in the near future. But in general, these are screening tests. They need to be followed by a diagnostic test, and that diagnostic test is a colonoscopy. And what to know about that is that timing is important. So most studies show that after 6 months, the risk of neoplasia or advanced neoplasia goes up. So risk of finding an advanced precancerous polyp is significant. Risk of finding any colorectal cancer, about a half-fold increased risk, and then over a 2-fold increased risk of advanced stage colorectal cancer if you wait longer than 6 months after a positive stool test. So, that's coordination between GI and primary care and everyone else to get patients in for their diagnostic colonoscopy within 6 months if they do have a positive test. And really the strategy here is, like I talked about last time, the best test is the one that gets done, but you really need to talk to patients about what it would mean if they have a positive stool test and prepare them for the need for colonoscopy if it is positive. Because if patients think that they're just getting this test instead of a colonoscopy, but then it turns out it's positive that they need the colonoscopy anyways, they may feel that they were tricked or something like that, and they may then not agree to get the colonoscopy, which defeats the entire purpose of the screening test. All right, so moving on to kind of the bulk of tonight's talk, which is we're going to be focusing on genetic risk and how we identify that and how we manage it. So we are going to delve a little bit into the weeds of the various genetic syndromes. I don't think this is stuff you guys need to memorize or know, but if you are working in rural areas where you don't have a ton of specialists to refer your patients to, it is a good idea to just understand the basic concepts of how you would manage these types of patients. So this pie chart on the left breaks down all colorectal cancer. And you can see here that the vast majority, or 65%, the dark blue segment of the pie chart, is sporadic colorectal cancer. So most people diagnosed don't have a family history, don't have an identifiable genetic predisposition. About 25% of people have at least one, family history that would increase their risk. And then only 10% or so of colorectal cancers occur in people who have a known genetic modification that increases their risk. So what about family history? So at least the studies that are available that have looked at this suggest that if you have one first-degree relative with colorectal cancer, you have a 2-fold increased risk yourself. If you have greater than 2 first-degree relatives, 2 or greater, let's just say, then you have a 6-fold increased risk. A single second-degree relative is about equivalent risk. And then in general, risks increase with early onset in the first-degree relatives. So there is a difference if your father had colorectal cancer at age 80 versus age 45. 45 would mean that you're probably at higher risk. So how do we approach these patients with a positive family history? So if they have a single second-degree relative, their average risk, they should just be enrolled at any screening program at age 45 and continue in that screening program. That can be non-invasive testing, colonoscopy, whatever they prefer. If they have 2 or more second-degree relatives, they are at increased risk. They should begin at age 40 or 10 years prior to the youngest age of onset in their relatives, and then repeat every 5 years. And then single first-degree relative over 60, increased risk, begin 40, repeat every 5 to 10 years. It depends on the guideline you look at. Some guidelines say 10 years is fine, some will say 5. And then a single first-degree relative younger than 60, almost all guidelines will say start at age 40 or 10 years younger and then repeat every 5 years. And if they have multiple first degree relatives, similar story, 40 or 10 years younger and repeat every 5 years. And I would note here that for most guidelines, an advanced adenoma, so that's an adenoma larger than a centimeter or that has tubulobillous or high-grade dysplasia, is equivalent to colorectal cancer when you're considering risk. And so if the disadvantage here obviously is that most people don't know the polyp history of their relatives. They do know the cancer history, so that can be hard to decipher. But if you do know that you have a patient whose father had, a large adenoma at a younger age, then that patient should be referred for earlier screening. All right, moving on to the genetic syndromes. So this is where we're getting to the weeds a little bit. I think it's helpful to just kind of take a step back and think about the two main classifications of increased risk genetic syndromes there are. There's hereditary non-polyposis colorectal cancer, which we all know is Lynch syndrome, and variations of that. And then there's polyposis syndromes, or commonly we know that as FAP. So if you have a patient who has a ton of polyps and develops cancer, that's probably FAP. If you have a patient who doesn't have a history of a lot of polyps and develops cancer or early onset cancer, that would be Lynch syndrome. There are additional subsets within those two classifications. So there's, Peutz-Jeghers syndrome, which is not the same type of polyp as FAP, it's hamartomatous polyps. And then similar to Lynch, there are other kind of mismatch repair or genetic mutations that increase your risk of cancer without necessarily leading to a bunch of polyps. And that's things like CHEK2 and even the BRCA mutations have some increased risk of colorectal cancer. So lifetime risk, depending on the mutation, for the high penetrance mutations in Lynch, that's MLH1 and MSH2, you have up to 80% lifetime risk of colorectal cancer. For the lower penetrance ones like MSH6 and PLS2, that risk is significantly lower, 10 to 22%. CHEK2, which is hereditary breast cancer gene, there's a 1.5 to 2.5-fold increase. Life remaining, 8 to 16%. FAP, pretty much 100% risk of colorectal cancer in their lifetime. Those patients get colectomies when they're diagnosed. For that reason, there is something called attenuated FAP, which just means they have the mutation, but they don't seem to have the number of polyps that you would expect to see in FAP, and so it's almost like a low penetrance FAP. Though even those patients still have a very high lifetime risk of colorectal cancer, up to 70%. MAP, or mu-Th-associated polyposis, very similar to FAP, up to 100% lifetime risk. And then for Peutz-Jeghers, it's about 40, and for juvenile polyposis, about 50%. So these are all, and these are not every single condition. These are just the ones that are probably the most common that we do see. All right, so how would you identify patients in your clinic who should be considered or to be referred for genetic testing or counseling? So in general, there's some rules. There's very specific criteria, which is mostly used by insurance and things like that to get approval for germline testing. But in general, think about any patient with lots of polyps or early onset cancer or recurrent cancer or multi-generational family history of colorectal cancer or other Lynch-associated cancers like uterine or renal pelvis cancers. That should raise alarms in your head. So what are the specific criteria? So for polyposis, any patient who has 10 or more adenomas on a single colonoscopy or a lifetime of 20 more adenomas meets criteria for genetic testing for FAP. And then for Lynch syndrome, there's the Amsterdam criteria and the revised Bethesda guidelines. So the Amsterdam criteria follow the 3-2-1 rule. So a patient who has 3 members of a family with a Lynch-associated cancer, at least one has to be first-degree relative of the other 2. And then there has to be 2 or more successive generations affected, and one family member has to have been diagnosed with that cancer under the age of 50. So those patients will meet criteria for screening for germline genetic testing, and Medicare and most insurance companies will pay for it. The revised Bethesda guidelines, also covered by Medicare and most insurance companies. So colorectal cancer, this is if that patient has any of the following: a colorectal cancer diagnosed, and any patient under the age of 50 will get screened for Lynch syndrome. If they have a family history, personal history of synchronous, meaning they are diagnosed with 2 different cancers at once, or metachronous colorectal cancer, So that means that they have cancer and then they develop it again later on in life. Anyone who has colorectal cancer with microsatellite instability under the age of 60, though that is kind of a moot point because at most centers around the country, everyone diagnosed with colorectal cancer is now screened for microsatellite instability, which is just essentially a screening test for DNA mismatch repair defects. And that would then, if they are MSI high, that prompts germline genetic testing to look for Lynch-associated mutations. And then the family history, so colorectal cancer diagnosed in a first-degree relative with a Lynch-associated tumor, one that's in any, and the diagnosis is less than 50. And then colorectal cancer diagnosed in 2 or more first-degree or second-degree relatives, regardless of age. If they meet those criteria, they meet the Bethesda guidelines, you can refer them for genetic testing, and most insurance companies, including Medicare, will cover the cost of it. And then we're going to close this discussion by talking briefly about the management of these patients. Like I said, this may be helpful to you if you just don't have access to a specialist. In general, they're managed by GI doctors or surgeons. So for FAP, the management is a colectomy at diagnosis, and then you still have to surveil the remaining rectum or ileal pouch, depending on their postoperative anatomy, every 6 to 12 months. They should have an EGD starting around age 20 to 25 or whenever they're diagnosed, and then repeat that based on the initial findings. There's something called the Spiegelman's classification, which you likely do not have to know. It just classifies the number, size of their polyps in their small intestine if they have any, and that determines how frequently they should get endoscopies because it determines their risk of duodenal or other small bowel cancer. Most of these patients will get a video capsule endoscopy at least once just to look for a large small bowel polyp burden. And then they should be screened for thyroid cancer as well with the ultrasound every 2 to 5 years. Management of Lynch syndrome, colonoscopy starting at age 20 or 5 years prior to the age of earliest colorectal cancer diagnosis in their family, and then they should repeat every 1 to 2 years depending on the number of polyps they have, or if they're found to have dysplasia or anything like that. There's established literature that shows that aspirin is protective. The optimal dose is unknown. The studies that have looked at this looked at 360 milligrams, which is a high dose for a lot of people to take every day. So oftentimes we'll just use the 81 milligram, telling patients that we don't know the optimal dose, but there likely some benefit from any aspirin. Women will get a hysterectomy and a oophorectomy after they're done with childbearing. These patients should get EGDs as well, starting at age 30, and then because of the risk of bladder and urinary cancer in general, they should get a urinalysis annually. I'll note that the lower penetrance mutations like PMS2, they don't get as frequent colonoscopies or EGDs. All right, so that is pretty much everything you need to know about, I think, increased risk in colorectal cancer. So okay, we're going to take the whole time. I do have 2 cases just to kind of slam home some of the points I talked about, so I'll go through those really quickly. First is we have a 68-year-old male planning to undergo a hip replacement. Surgeons get preoperative blood work and incidentally notice that he has hemoglobin of 8.2 and a ferritin of 6, noting that his blood counts were all normal 6 months prior. He has no other symptoms aside from fatigue and reports that he had a normal colonoscopy 7 years ago. So wisely, they refer him for an EGD and colonoscopy prior to undergoing a hip replacement, and then this is found in his ascending colon. So this is essentially almost an apple core lesion. I was able to get through this to the cecum, so not a complete obstruction, but this kind of gives you an idea of how much a cancer can grow in a patient before they start to have, obstructive symptoms or really any other symptoms. And in this patient, aside, if he hadn't been going in for that hip transplant and gotten that blood work, he, may have not even known about this cancer until much further down the line. Case 2, it's a 34-year-old male, presents to clinic, 6 months of rectal bleeding, no weight loss, any other symptoms really, and then an in-office exam did reveal large external hemorrhoids. He had no family history of colorectal cancer, but he was referred for colonoscopy. So this is a patient you probably could get away with doing a flex sig based on most guidelines, but he was sent for colonoscopy, and this was found in his sigmoid colon, so it would have been picked up on a flex sig. but it's about a 2.5 centimeter pedunculated polyp that was bleeding. You can see from this picture. It was completely removed, and the pathology revealed an adenoma with high-grade dysplasia. So this is a polyp that almost certainly would have turned into cancer if left in there. And this is in a 34-year-old with really no other risk factors other than rectal bleeding. So I think that just kind of slams home the point that you can't really ignore these symptoms, even if you're reassured by the patient's age, the fact that they have hemorrhoids, things like that. You'll need to do the due diligence and rule out other potential more important causes. So with that, that's all I have. I'm happy to take questions, comments, anything like that you have for the remaining, I don't know how much time I have, 5 to 15 minutes or so.